All right, we're moving on to pediatric and geriatric imaging. So childhood vulnerability. Your pediatric patients are more vulnerable to radiation. They are essentially smaller, right? But they absorb more radiation per volume of tissue than adults. They're also still growing, which means they have more cell divisions happening, and which makes them more radiosensitive than adults. They also have a longer lifespan than adults. So there is more possibilities of seeing some results of a radiation-induced cancer or something like that. Some principles of pediatric imaging. An essential to success is understanding that children, they're not just small adults. I think they're their whole different being, right? They need to be approached at their level. Don't speak to just the parent. Include the child in any of your communication skills. And the two main areas of problems in radiographer confidence for pediatric imaging is communication skills and immobilization techniques. The child will be less likely to be upset or agitated if the room is prepared before he or she enters it. You as a technologist will be more confident as well. If you have prepared your entire room, your technique is set, you have everything out, you have a shield out for the child, a shield out for the parent, you have your markers out, you're in detent, you're ready to go. The only thing you have to do is talk to that family, change the child, position the child. It really relieves stress all around for everyone. An approach. So you have to think about pediatric patients as there's always two patients that you're dealing with, the parent and the child. If the child's old enough to comprehend, speak directly to them. Use language that's appropriate for their level. Obviously, if it's an infant that's too young, you'll explain to the parent only. But use simple sentences. Be aware that parents will be stressed and distracted. But simple instructions will get you through most of your pediatric exams. Don't go into too much detail. Don't go too far. If your parent's agitated, introduce yourself. Realize that the agitation most likely is fear for their child. They just don't know what's going on, and parents are really aware of their children, and they know when something's going on with them. So just try and listen to all their concerns without interrupting. Don't make assumptions. Listen to everything. Document what they're telling you, and then just try and provide some explanation and comfort if you can. If you can't answer their questions, find someone who can. Find another technologist, find clinical instructor, pull the radiologist in, call someone up from medical physics, depending on their concern for radiation doses and that kind of thing. But making them comfortable is key to your success in your exam with PDs. Parent prep or parent participation. So some of your parents will prepare their children very well. The child will know what is going to happen to them when they come in, and it can go either way, right? But they will at least have some sort of idea why they're coming into the hospital and what's going to happen to them. Some parents do not want to tell the child anything preparation-wise. The child has no idea where they're coming in. In my experience, the children that have some sort of idea, the parents that have prepped them prior to, do much better. I usually try and keep only one parent if I can. That just goes a little bit easier. There's not a lot of discussions in between, so I ask one of the parents to step out. Depending on the size of your room, too, it's definitely a little bit easier just to have one parent. And I usually take the male, I don't know if it's dad or if it's uncle or whoever it is, but more than the mom, okay, who could be possibly pregnant, something like that. So always ask any chance of pregnancy for any female parents that come in the room. And if the parent's going to stay, they have to have a lead apron on. There are some advantages to having the parent. The child may be a little bit more relaxed with the parent in the room. They can be aware of what's happening to their child, so they won't question what's happened to them while they were in the room. They can assist and hold the child down. if you need to step away from the table, they can be responsible for watching the child, something like that. For your approach, try and get down to their level. If you can, get down on your knees, look at them eye to eye. It's very intimidating to be a small child and have an adult sort of towering over you. I always ask the child, who'd you bring with you today? Depending on how old they are, obviously. Say, hey, who'd you bring with you today? Never assume that it's mom and dad. It may be foster parent, it may be grandparent, it may be older sibling, it may be a step parent, something like that. So I try and ask them first so I don't stick my foot in my mouth. And then, just explain to them what's going to happen. Your attitude is really important. So having a positive attitude and a positive approach to pediatric procedures, even though if PDs aren't really your favorite thing, try and be positive about it. And in your approach, I swear they can sort of smell fear. So I always try and compliment them, especially your 3-year-olds. They really do well with that. Wow, you did awesome. You were very still. Thank you so much. Distraction techniques, talking to them about other things to sort of distract them from what's going on. Do you go to school? Do you play any sports? Do you have any siblings? How about pets? Do you have any pets at home? What's your favorite TV show? Do you have a song that you like? Something like that. So they will be more distracted than what's happening. Say the radiologist is working on something and they need some distraction. You can utilize that as well. Be honest. Don't lie to kids and or any of your patients. Just be honest. This is going to hurt initially. If they're getting a catheter placed, don't tell them it's never going to hurt, because it does. It hurts. So be honest and, explain to them exactly what's going to happen. At the end, when the catheter comes out, you will no longer feel it. It won't be inside. Keep it basic though. All right. There are certain age-specific needs. So definitely your infants up to 6 months old, you want to keep them warm, secure, nourishment. So, the infants, they're pretty happy as long as they are wrapped up in a warm blanket. So be aware of the heat level in your room. Get a blanket of the warmer. Make sure they're covered. Make sure they're tucked in. They're startled by loud stimuli. So the loud kind of clunking noises of your x-ray tube. So if you can have that equipment in place. I always ask my parents, do you have a pacifier that they like, a familiar object? So do they have a toy that you want to bring onto the table with you just in case? I like to be ready for anything. So if they start screaming, if you have the pacifier or the lovey or whatever it is ready, it's good to have. 6 months to 2 years, they're fearful of pain. They fear being separated from the parents. They do not like to be held still. They want their legs and their arms moving, right? They want to be sort of all over the place. So be prepared for that. 2 to 4 years. These guys are really curious. They've got their imaginations going. They like games. They respond to praise and they respond to bribes, and usually stickers go a long way for this age group. 5 years. This varies a lot. So depending on the confidence level for the child, they're going to go either way. They're either going to cling to the parent and act much younger. So they may cling to the parent and act 2 to 3-year-old. They may be sort of in a comfortable, as long as the parent is close by. And some 5-year-olds are really confident and communicate extremely well. 6 to 8, this is the ideal sort of age for your inexperienced radiographer, your student x-ray. 6-year-olds are key for you guys for comping. They're pretty eager to please. They usually communicate well. They're modest, so they're just aware, really starting to sort of be aware of their bodies too, and the concept of privacy and not getting undressed in front of people. So just be aware when you're asking them to change that you're giving them, some room for privacy or taking the parent's lead on that. Preteens and adolescents, they can understand, but they may not want to cooperate. They may be worried about either the exam or what's going to happen after, and sometimes they're just sort of afraid to ask you. But just be clear in your explanation, answer any of their questions. This is a tough spot to start asking about pregnancy. Trying to ask without the parent in the room. Definitely asking, have you started your period yet, is an easier question for, say, between 10 and 14 than any chance that you're pregnant. So I tend to go with, you started your period yet? As my first question leading in, trying to get that information from them. Your special needs patients. So just because they say that just because it says 18 on your requisition, they may be at age 6 mentally. But never assume that that's where they're at. I always definitely go with the parents, or if there's a caregiver with them, I take their lead. So they may have some abilities physically, and some may not. So every child's different, and your special needs child is the same, right? So, but I always speak to them in the same manner, and I speak to the parents the same as well. But I always ask, is there something I can do for your child to make this go smoother? And I ask for any tips and tricks every time I have any child, really. The parents know their kids. Outpatient, it's usually your easiest and less stressful. They're coming in, they can usually walk in, depending on, how old the child is. Your inpatient, they're a little more stressed because clearly there's something going on with them for them to be in the hospital, right? So the doctors want them here so they can monitor them. They're doing some testing to see what's going on. The parents definitely are stressed. Their child's admitted to the hospital. They may have other kids. They may have work. They're worrying about the health of their child. They may be worrying about money and health insurance and everything that's going on. So definitely more stressors with your inpatient pediatric than your outpatient. There may be some urine or stool collection happening. So if you get an inpatient pediatric that has a diaper on, if we change the diaper, we want to save that and send that back to the floor. Know your policy on IV lines. If the IV line starts beeping, don't just turn it off. Call the nurse over, either in CAT scan, or if no one's available, I call the nurse from the floor and ask them to come down and check the IV. Immobilization versus restraint. Restraint. It's usually used within the mental health settings. It's forcible confinement, limitations, or restriction. It also requires orders from a doctor. So immobilization is a general term that we use within healthcare. This is something we can use to hold children still, or anybody still, really, in our area of radiology. So it should never be a traumatic, torturous event for a child. It shouldn't cause harm. So be aware of the adhesive service of the tape. If you can, try and use the paper tape. Communicate. Tell them what's going on. Short exposure times are key in any time you're trying to prevent motion on your images, okay? Especially PEDs. And so your pediatric competencies for your program, the children must be 6 years old or under to count for pediatric comps. The PD chest is mandatory. Abdomen, upper extremity, lower extremity are all electives. In the extremities, you can choose any from the list. The mobile chest study in the NICU is a mandatory elective for us for our program.